Thank you, Vanati. I have no financial interest. We will not go into the details of what an amniotic membrane is and why we'll only see why we use it and where we use it. So I have used it for persistent epithelial defect, neurotrophic keratitis, post-OSS excision, after pterygium excision, after debriding a shield ulcer, after anterior stromal puncture, after chemical injury in the acute phase, also chronic phases, amniotic membrane graft with slit, after superficial keratectomy and combined with EDTA chelation. You can use it as an inlay inside or onlay, multi-layered, or as a bandage. So when I finished my fellowship in the year 2001, amniotic membrane was not widely available. So we have tried freeze-dried membrane with gamma radiation, very much like a tissue paper, and difficult to suture, but better than nothing, and you get large quantities. We have also used non-preserved amniotic membrane. That was the first thesis I had given my resident in persistent epithelial defect. Worked pretty well, but then the caveat that you have to wait for 6 months to see that the mother who had given the placenta does not have any immunological problems like HIV and other stuff. So, well, you can use it, but a little bit of, you have to be careful here. Otherwise, now AMG is abundantly available in Dalbeco's modified Eagles medium. And here we see a case of SJS. One on this side, this patient still follows up with me. He had a perforation, and we had done an amniotic membrane graft. One should understand, doesn't have much of a tensile strength. Here was another patient. At that time, I think Shweta and Geeta had not come up with AIOS2025. So we had just done an amniotic membrane graft at that time, and that was what was advocated in our fellowship. And the patient did pretty okay. In acute SJS, of course, the many papers by Darren, Gregory, and others have said that amniotic membrane in acute SJS, there's a very small window period that you have. And if you are there in a multi-specialty hospital, or you can go to the ICU and do the amniotic membrane graft. And the long-term follow-up of these patients who have had AMG in acute phases of SJS have done far better than those who did not have. So here's one such paper by Darren Gregory, which showed the amniotic membrane graft, which is just melting here, but the long-term follow-up was pretty good. And we have also done that. And some of our colleagues in the plastic department have gone into ICUs of the multi-specialty hospitals. The key is also to cover not only the bulbar, but also the tarsal conch. Here's a case of OSSN, which we had done long back. And after removing the OSSN tissue and doing inverse freeze-thaw cryo, can apply the amniotic membrane to the surface. That is one indication. The other indication, as we said, in a shield ulcer, this was a young chap, long back, this was about 7-8 years ago, and we had debrided quite a bit, so we put a multi-layered amniotic membrane here. He did fairly well, only for the shield ulcer to recur again. Right. Along with that, like Dr. Sunita showed, you can give a supratarsal injection at that point in time. In a pterygium surgery, where there is you can use an amniotic membrane graft, but the recurrence rates are pretty much higher there. Or in a recurrent pterygium, if you're not sure that the conj is there, or in a patient who has got a filtering bleb, you might take it from the inferior conj. Or if it is a double pterygium, you can use the autograft, divide it into two, or use amniotic membrane on one side. So another resident got a thesis here. So the recurrence rate was pretty much similar with glue. This is quite high. That was about 20 years ago. And this is another patient where we did an anterior. There was no visual prognosis, and she had a lot of pain and watering. So we did an anterior stromal puncture along with an amniotic membrane graft. You can just do an AMG with just a bandage contact lens. You can also peel the epithelium, put the AMG underneath it, put the epithelium back there like an inlay procedure. And a lot of our patients are very comfortable after this procedure, after the AMG and ASP. Is it going? Yeah, and long back, another resident had a thesis with superficial keratectomy and AMG. At that time, we did not have the excimer laser. So we were doing, and neither do we have an intra-op OCT to see how deep we are going. But we have a lot of patients with climatic droplet keratopathy who are miserable with all those globules there in the anterior part. And here's another patient with a nevus who had an excision. with an amniotic membrane graft. You can primarily close the conj also on top of it, but the graft probably, and you can see that in some cases we have used the fibrin glue with just one needle. That was when we were using the Diplojet syringe. Then we realized we could use more of the glue like this in the lower part, which separate the fibrin part and the thrombin part. The fibrinogen and the thrombin we are using separately. So this we had published in AMG before Dr. Vanati had become the editor. And this is another nice video from ocular surface workshop which I had attended, and asked Dr. Shayan for his permission to show this, because he has done an excellent excision, done a limbal biopsy, and used that on top of the amniotic membrane graft by using small pieces of the limbal biopsy. There are many techniques of doing this. People have done it as a mini slit in pterygium. And what we know is we have to put it in paracentral area, not in the center, because it can cause a little bit of central opacities there. The amniotic membrane is applied after doing a pannus excision. We have seen in some patients when we had done this pannus excision and put the amniotic membrane graft, in the second sitting, suppose the pannus recurs, it's such a beautiful plane that you get, that you can actually get a shining surface underneath it. So you can put the sled buttons. You can do, if it's bilateral, you can do an AIOS also without doing immunosuppression after that. And a lot of people now recently, they have put the sled buttons or the AIOS directly on the corneal surface, or they have used a sandwich technique, that is put one layer of amniotic membrane, put the sled buttons, put another layer of amniotic membrane. Makes for good publications when you do different types of procedures. But ultimate result apparently is the same. The amniotic membrane is just a basement membrane on which, so this is it's just a basement membrane, no epithelial cells. You put the epithelial surface up, the stromal surface down, which is sticky. It can also be a carrier for limbal, cultivated limbal cells. Here you see a case of thermal burns where the amniotic membrane graft worked pretty well. In our hospital, we have used amniotic membrane in several conditions, and thank you for your kind attention.
Thank you, Uma. And as Dr. Shweta is setting up